feeling?
I feel okay. I've been having some, like, not problem, but like, I've been having some pains breathing since I had the lung biopsy. And it's been like, some days, like, it was good, and then like, it just started hurting really bad again to breathe. I did fall on my side, so I don't know if that had anything to do with it.
It's possible. Because you had the biopsy done like 2 weeks ago, I think, wasn't it? I have it here, actually, okay? We have the results, as a matter of fact. Okay, so you had the biopsy done on, what does it say here? 11:30?
Mm-hmm.
And then you had the immunobiopsy done on 11:28, okay?
Yeah, yes.
And so 11:30, that's about 2 weeks now, okay? It's a little bit too late to be hurting in your lung, okay? Especially if the pain counts got better after that, okay? We do expect a little bit of pain from a biopsy, okay, in the lung. Usually within a day or 2 or 3, it starts getting a lot better, okay? A week later, you may feel a little bit of soreness, okay? But not much else, okay? And so if you're hurting, especially to breathe in, to breathe out, not sure if maybe perhaps there's something else going on, okay? And especially if you fell, and that's when the hurting kind of starting back again, and I have a feeling that it's probably that trauma, okay? I'm not too worried about the lung itself, okay? The lung, the needle is very small that they use, okay? But with the trauma that you had with that fall, I don't know if maybe perhaps you could have punctured the lung a little bit also, okay? Are you short of breath at all?
Like right now, not like a little bit, but not like major.
No, not major, okay. You basically hurt when you're taking deep breaths, I presume?
Yes.
When you kind of sneeze or cough?
When I yawn like all day, so like, it's like when I really get like, get a good yawn, like sometimes, like it's, like yesterday, or the day before yesterday, it was like better. Then yesterday, I was pretty much good all day, and then one yawn was like, it got me, like I felt like I got jabbed in the rib.
But you're not hurting all the time?
Yeah, but like today, like it's not hurting.
Okay, very well. So I think it's just basically bruising of the rib vein, maybe, okay? Now if you're having shortness of breath, that's a different story. You need to go to the emergency room right away, okay? So don't second guess. Okay, it's okay. I got the biopsy results at this point, okay? Both the lung and the nodule in your groin show the same thing, okay? And it is a testicular cancer.
Okay, so I do have cancer now.
Yes, you do have cancer, and it is testicular cancer, okay? And when you were in the hospital, again, the urologist didn't want to do surgery, okay, remove the testes, because he was not sure whether this was testicular cancer or not, and he was worried that it was maybe something else, like a lymphoma, okay? And so we waited for the biopsy, okay, to do anything thereafter, okay? Now, the cancer is already spreading, okay? So it's in the groin area, it's in lymph nodes in the back part of your abdominal cavity. It has already migrated into the lung also, okay? The tumor in the lung, okay, the nodule in the lung shows the same thing as the groin, actually, okay? And it is not uncommon for testicular cancers to move about the body in that fashion, okay? Only thing that is a little bit on the off side, or the strange side, is that we don't really see a dominant tumor within the testes, okay? Maybe around the testes, okay, in the spermatic cord, okay, certainly the groin area, of course, the nodules in the groin area. How's that feeling, by the way?
That's actually been, I've been feeling like I feel like it's gone down.
It's gone down a little
bit. But I also feel like there's been like, just on like random days, like I felt pressure all right there.
So, it's good that it's not gotten bigger also, okay, that you're not telling me like, oh no, it's getting bigger and it's getting bigger by the day, okay, and that's very, very good. We do need to act relatively quickly, okay, because these cancers are aggressive. They can grow pretty quickly. They obviously can spread, and they can spread early on relatively fast, okay, and so it's not one that we can say, we're going to take our time to do the workup and to do all the evaluations, okay, and 3, 4, 5, 6 weeks down the road, we start treatments, okay, because in that time frame, this can actually get even worse, okay?
Yeah.
And you probably saw some of that, okay, basically in the time from you developing that nodule there, okay, to when you came into the hospital.
Yeah, because that was as short as like a couple months, and then I guess I had a test done that they checked, like, or they did scan, and that was in the beginning of November, and then the end of November, now there's something in my lungs, so like, I know it's spreading pretty quickly.
It was a very short time, and things were kind of sort of evolving almost before your eyes. And so, yeah, it can do that because they are a little bit on the aggressive side, okay? At this point, because we know that this is moving throughout the body, the more important thing is basically getting good control of the cancer quickly, and we can do that with chemotherapy, okay, primarily chemotherapy, okay? So we'll do the chemotherapy after several courses of chemotherapy. We'll see how the cancer has responded, and at that point, maybe send you for radiation therapy, okay, or for surgery, okay?
Okay.
And the surgery would be basically removing whatever remains in the body at that point.
Okay.
Yes, sir.
So if I had to get surgery, what would they do with the lung? Would they remove the lung, or?
No, in the lung we probably would either radiate it at that point if there's anything remaining there. Okay.
Oh, okay.
The nodule in the lung is relatively small. It's not really that big. Okay. And so I'm not too worried. Now, if there's something that remains there, okay, so I'm presuming that the lung nodule or the lung nodules will disappear with chemotherapy. Okay. In which case basically goes away fully treated at that point, nothing more to do in that
Okay.
case, okay? But if there is something that remains, a small nodule that still remains that just doesn't want to go away, certainly we could remove that nodule, okay, surgery basically, or we can just do a short course of radiation therapy to that lung nodule basically to make sure that there's nothing left of cancer in that.
Okay.
Now, testicular cancers, okay, germ cell cancers are very responsive to chemotherapy. They melt away, they go away by and large, okay? And in most cases, everything really truly disappears, okay? It's one of those cancers where basically anything that remains behind, we cannot just basically assume that it is scar tissue from the nodule that was there, from the mass that was there, because we cannot say for sure if there's still cancer cells within residual mass, okay?
Okay.
So this is one of the cancers where basically we say if we see anything on scans, we either have to biopsy to make sure that there's nothing cancer remaining there, or take it out, okay? If it is not possible to do either of those, then radiate it, okay? To get rid of whatever cell material may be remaining with that,
Okay.
because we don't want to leave any cancer behind, because then we get, at that point we're risking a chance of the cancer coming back again. And usually when it comes back again like that, it comes back even angrier, okay?
Yeah.
It becomes a more dangerous disease altogether.
Okay.
Because of the cancer, where it's all over your body, basically, at this point we can basically say that it is a stage 3 cancer, okay? Testicular cancers, yes.
Okay.
Testicular cancers are stage 1, 2, and 3. So even though the cancer is spreading throughout the body, even if it's moved into lungs, basically we don't go a stage higher than 3 at all for testicular cancer, and it has to do with the fact that people survive that cancer really well altogether, okay?
Okay.
And there are subcategories, okay? There's subcategory 3A, 3B, 3C. Usually has to do with tumor markers and how they're behaving as we're doing the treatment, okay? So as we do the treatment, we'll know a little bit more, better define how your stage really truly stratifies. Okay, right now, I think I was looking at your labs and everything else, and you're still a stage 3A, okay?
3A?
3A,
Okay.
okay? Which is not bad at all, it's actually very good.
Okay.
Very, still very, very reasonable chance of a cure altogether.
Okay, cool.
Yes, sir.
As far as the chemotherapy,
Yes,
or
sir.
I don't know if it's chemo or if it's radiation, which one am I gonna lose my hair on? Like, I'm just
How
curious.
soon were you going to lose your hair?
Yeah.
Probably after the first chemotherapy we give you, like 2-3 weeks on the road.
Oh, well, that fast. Okay.
Quickly.
Cool. So
Okay.
then, do I lose like all my hair, like my eyebrows too, or is it like?
No, it's just primarily your hair, okay?
Oh, okay.
I mean, most people still keep some facial hair, okay? For whatever reason, facial hair doesn't seem to go away completely, okay?
Okay.
You will notice that it's not growing as much, okay? So shaving, sometimes, guys going through chemotherapy like this say, well, I shave like once every 2 weeks or so because there's not a lot of growth in the interim.
Okay. And I already don't. Well, I mean, like right here, I grow, but I barely started. I didn't even go all the way over
Yeah.
here. So like, I don't go a whole lot here.
Yeah.
Right? Yeah.
So it's gonna lighten up a little bit, okay? And you may end up losing some of your facial hair also. Okay? The longer course of chemotherapy we give, the more likely that you do end up losing some of that
Okay.
hair, okay? In your case, we're basically projecting 3 to 4 cycles of chemotherapy, and that's it.
Okay.
Okay, so it's a relatively short course altogether, okay? Only thing is that the treatments are, each cycle of chemotherapy, each course of chemotherapy, is over 4 weeks, okay? About a month in duration.
Oh, for one
For
cycle?
one cycle to go
Okay.
through, okay? And you get chemotherapy peppered throughout that month time frame, okay?
Okay.
Not every day, not even once a week, okay? But throughout the month, you get a little bit of chemotherapy here and there. About every 2 weeks, you're getting chemotherapy, basically.
Okay.
Okay? And we do the chemotherapy in the infusion clinic, okay? It's an outpatient treatment altogether, okay? And so you go in, you get your chemotherapy, you go home, okay?
Okay.
It is pretty toxic, okay? I will be honest about that, okay? It's pretty toxic in terms of nausea, vomiting.
Okay.
The agent that we use to treat the cancer is a platinum medication, okay? It's called cisplatin. Very, very active, very effective in treating testicular cancer, but it is one that causes a lot of nausea and vomiting.
Okay.
Although we give you plenty of good medications to try and not have that side effect, okay? Even with that, you still end up with some problems of nausea, vomiting. And it is not that unheard of altogether, okay?
Mhm.
That because of the nausea or the vomiting, okay, that the patient has, that you may end up in the hospital for intravenous hydration periodically here and there.
Oh, okay.
The thing that I tell patients, okay, is try and push as much fluids as you can so we can avoid a hospitalization, okay? I'm pretty good about giving orders to the nurses to give intravenous fluids in the clinic, however the patient needs it.
Okay.
And even if you need to go there every day to get a little bit of intravenous fluids to try and keep you from getting so dehydrated, do so, okay? Because that may be the difference between staying out of the hospital or ending up in the hospital.
Okay.
So if you're having problems with nausea and vomiting that is not really getting controlled with the medications we give you, you need to let me know so we can try and help you so you can stay out of the hospital.
Okay.
The goal is basically to keep you out of the hospital as much as possible.
Yeah.
Okay. Make sense?
Mhm.
Good.
So like, will like this, like I'm scared will come back and like, will this be removed eventually?
So if it goes away completely, nothing to worry about.
Okay.
If there is some radiation mass there, okay, either radiation therapy or removing it.
Okay.
So your copies, okay? Now, in the hospital, they were going to put a port, if you remember.
Yes.
And I told them, let's go ahead and nick the port, but do the lung biopsy instead.
Yes.
And so now we're going to need the port, okay?
Oh, we need to do the port?
Yes, sir. Okay.
Alright.
We need to do the port. We need to do pulmonary testing, okay? Because one of the chemotherapies that we use for testicular cancer is called bleomycin, and that can have scarring of your lungs, actually. Okay? You don't smoke, do you?
No.
Okay. And in the injuries that you've had in the past, were your lungs hurt at all? Your trunk, your chest?
I know these, like, for a while I was on that respirator in the hospital.
Yes.
And, like, they didn't want to take me off of it completely, like, until my breathing was above so much percent.
Correct.
And then, so that was, like, the only thing. So I was on that for, like, at night or in the morning.
Okay.
And then, but, like, it got to a point where they said I don't have to, I don't have to be on it no more.
Yeah.
I know I don't breathe, like, 100%. I definitely don't feel 100% breathing. But I don't feel I need a respirator. Right?
Correct. Okay. So, I mean, and it was not injury to your lungs. It was more like a neurologic.
Yeah,
dysfunction.
I was the brain stem.
The brainstem, exactly right. And so it was basically lack of innervation of your chest cavity to be able to breathe for you. But very good. That does not worry me too much because that should not have any impact on this medication altogether. The injury that this medication can do in the lungs is actually scarring of lung tissue itself. Okay, that can interfere with the breathing. Okay, and so we'll have to keep an eye very closely as we do these therapies. On the good side is that we're again limiting the amount of chemotherapy we're giving you. Okay, so don't expect that you'll get any of that injury. Certainly don't smoke. Don't smoke pot. Don't smoke cigarettes. Don't do vaping or anything like that. Okay.
Okay. Could I smoke crack? I'm just kidding. I don't smoke.
Sure, you can. Okay. No smoking. Nothing inhaled into your lungs
Okay.
that we are not prescribing for you. Okay.
Right. Okay.
Okay. And so anything in this setting, even oxygen can be toxic, believe it or not.
Oh, well,
Yes,
okay.
sir. Okay. So, and you say, well, should I tell the doctors? Absolutely. If you go to the hospital for whatever reason and they want to just slap oxygen on you, you have to tell them, I'm taking this chemotherapy that can injure the lungs. Okay, so I can only take so much oxygen. Okay.
Okay.
Okay, so we don't want any excess oxygen because the oxygen can actually induce injury in the lung tissue after you've been exposed to this medication, okay?
Okay.
And so it's not just even during the course of chemotherapy, but for the rest of your life, basically.
Oh, it's gonna be like that for okay.
Yes, sir. Okay. You can get a little bit of oxygen, you can get some oxygen, but not a lot.
Okay.
And a lot is basically over 50%, okay, of oxygen, whether it be through a mask, okay, on a ventilator, okay? And so we'll just have to be very, very, very careful about that for the rest of your life.
Okay.
Okay. Now we can basically avoid that medication, but if we do that, then I have to extend the chemotherapy a lot longer. Okay. And we still worry a little bit about the curability of the cancer without using that medication. Okay.
Okay.
And so, if you were older or had injury of your lung tissue or had some chronic problem with your lungs, I would not have any reservation in saying, well, let's just not give that medication. Okay, and we'll just give more and more chemotherapy, much more chemotherapy. But that would be basically in a person who has very high risk of lung toxicity, who is maybe older, and the projected lifespan is not as long as for someone younger like you. And so for you, we have to be very aggressive about how we treat. Okay.
Okay.
Even if we consider that there are risks to the therapy.
Okay. You said something about earlier. We had to do like I can't remember what it was. It was something like I don't think preliminary was a word, or they said they had to do like something of that word, some test.
Pulmonary function test?
Yeah, I think so.
Okay, the lung exam, exactly right.
Oh, that's the okay.
That's the one, correct. Pulmonary function test, okay? In terms of the scans, I think we have everything. Remind me, when you were in the hospital, did they do a scan of your brain also or not?
No.
No? So that may be the only thing that I add to the staging criteria. And it's not even really truly fully indicated, okay? But I just want to make sure that we are not missing anything else. Okay?
Like if it spread to...
That's right. Okay.
Yeah.
And you say, can this spread to the brain? The answer is absolutely yes, okay? And if there are some, I mean, if we see the tumor markers very, very, very high, okay, the alpha fetoprotein, the beta ACG that are very, very high, then we're obligated to check in the brain to make sure that it is not down there.
Right.
If it is presenting in such a fashion, okay, where we see it in organs, okay? And you say, well, it's in my lungs. So for testicular cancers, we basically say organs affected by cancer other than lung. Okay, because we know that the cancer likes to go to the lungs actually, okay? But that does not really change the prognosis for the patient or the treatment in that regard, okay? So it's when the cancer goes to, say, the liver, to adrenal glands, to other organs, okay, that things are hairier altogether.
Right.
And so we talk about non-pulmonary visceral metastases, okay, meaning the brain, the liver, okay? And so the pulmonary metastases don't really qualify in that, okay? And so I don't want you to get panicked, okay, that you say, well, the cancer's already in my lungs, so it's going all over the place. And we say, well, it is probably getting to your bloodstream, and the potential to go other places like the brain, the liver, is still there, okay, but it is not, so far with the scans that we've done, we've not seen it there, and so we're still in a good position, okay?
Okay.
But I just need to make sure that there's something in the brain also.
Yeah, better safe than sorry.
Better safe than sorry, okay? And off the top of my head, I don't remember if the CT of the head is good enough or if we need to do an MRI, okay? Have you had MRIs of your brain before? Or you probably have when you
when I was younger, I know that. I don't know about when I was in the hospital.
Okay. What about since that injury?
But since that, I don't. I did do something when I was first got here, and I had to get taking my plates, disabled plates.
Yes.
I had to go get a doctor, and like he went sent me to another place. They put like all this stuff on my head to like scan my head, but I don't know if that.
Wondering if that was an EEG.
Yeah, that's what it was.
Okay.
Yeah.
Very well. And it was to see if you had any seizure potential. Okay. And so that one does not give you any good information about whether there's tumor in there or not.
Okay, I didn't think it
So I'll look up and see what imaging we have to do in your brain, whether a CT scan or an MRI.
Okay.
Okay? Fair enough?
Yeah.
Very good. So port placement, pulmonary function tests, and CT or MRI of the brain, okay?
Okay, so when do I get the port?
ASAP, okay? Because I want to get you started on chemotherapy hopefully by next week.
Okay.
Okay, is that all right?
Yeah.
Okay.
For sure.
Yes, I want to start you on chemotherapy as soon as possible.
I gotta call my job, so I can't do any double shifts anymore.
Well, what do you work?
That's a joke. I know.